This video will demonstrate the technique of hydro-implantation. Hydro-implantation refers to implantation of single-piece foldable IOLs under continuous irrigation without using OVD in anterior chamber or capsular bag. Hydro-implantation term was coined by Dr. Harshul and the technique was first published in Journal of Cataract and Refractive Surgery in 2010. After irrigation aspiration of cortical matter is completed, to prepare the incision, the automated irrigation cannula is kept in the eye, and if required, the main incision is enlarged to the desired size with the keratome. To implant the foldable IOL, irrigation cannula of the bimanual IA phaco machine is kept on continuous irrigation mode and introduced through the left side port. After it is placed in the eye, the irrigation cannula provides excellent stability and positioning to the eye, and it also keeps the anterior chamber and capsular bag well distended for PCIL insertion. The tip of the cartridge is then inserted into the anterior chamber, and the leading haptic and optic of the foldable IOL are slowly injected into the capsular bag. The trailing haptic, which remains in the anterior chamber, is dialed into the capsular bag with the help of a Lester or Coughlin's hook. The tip of the irrigation cannula lying over the unfolding optic of the IOL helps to prevent any tilting or inversion of the IOL. Hydro-implantation technique is very useful for toric IOLs, as any OVD left behind the IOL optic can cause post-operative rotation of toric IOLs and loss of their efficacy. So once toric IOL hydro-implantation is done, it's dialed to its final desired axis with the help of tip of irrigation cannula and Coughlin's hook. If needed, capsular axis can be secondarily enlarged to appropriate size via side port using microcapsular axis forceps under continuous irrigation. Hydro-implantation technique is not recommended for 3-piece foldable IOLs in cases where posterior capsule tear is there or where the anterior capsular axis is compromised. The hydro-implantation technique has the advantage of increased efficiency, reduced surgical time and cost, no need for OVD removal from behind the IOL optic, no need for additional instrumentation, no OVD induced elevated IOP post-operatively, and no risk of early capsular bag distension syndrome.